I wish to thank the organizer for inviting me. It gives me great pleasure to give this talk on lipids and obesity in CKD in this KDIGO-KSN Joint Symposium over the internet. These are my disclosures. Shen Nong is an ancient Chinese physician who over 4,500 years ago already observed a close relationship between the heart and the kidneys. Nowadays, of course, we know of a very close relationship in this what we call a cardiorenal link between the heart and the kidneys. And we already know very well that with decreasing kidney function, there is increasing risk of cardiovascular morbidity and mortality. So my talk today will be divided into 4 parts, focusing first on a recap on what the KDIGO guideline says about lipid management in CKD, followed by some recent evidence on the link between systemic inflammation and lipid abnormality. I will then move on to obesity and CKD and finishing with some novel experimental treatment approach for obesity-related CKD. So in 2013, KDIGO published this management of dyslipidemia in CKD guideline, and these are the guideline co-chairs. So the first guideline says that in adults with newly identified CKD, we recommend evaluation with a full lipid profile, and this is 1C, meaning a recommendation with low quality of evidence. We of course know that there are many secondary causes of dyslipidemias, and they are listed here on this table. And this is why we need to check lipid profile in all the CKD patients. Now 2.1.1 says that in adults aged over the age of 50 or above with eGFR below 60, but not treated with dialysis, should be offered a statin or a statin plus ezetimibe in case of dyslipidemia. And this is 1A, meaning a recommendation with high quality evidence. Now, where is the evidence? Of course, from the SHARP study, you may recall, almost 10 years from now, studying over 9,000 patients, and you can see that about a quarter of these patients were on dialysis, but over several thousands of patients actually had different stages of CKD, and these patients were treated with either a combination of simvastatin and ezetimibe versus placebo. And these patients were followed for a median duration of 4.9 years. And you can see the very nice splitting of these lines after the first year follow-up, so showing the clear benefit of lipid-lowering therapy in these patients with either CKD or dialysis-dependent CKD, favoring the use of lipid-lowering agent. Now, in adults with dialysis-dependent CKD, however, the guidelines suggested that statins or statin ezetimibe combination not be initiated, and this is 2A, meaning only a suggestion but with high quality evidence. Now, why do we not want to treat patients who are dialysis dependent with lipid lowering agent? Well, we can recall some of the randomized clinical trials, the 4D study using atorvastatin and Aurora study using rosuvastatin, and both these studies, you can see both the treatment line and the placebo line almost overlap. So meaning that there is actually no advantage at all in terms of reducing the cumulative incidence of cardiovascular morbidity in patients who are on dialysis. And indeed, if we look at the data of the SHARP study, looking at the major atherosclerotic events by renal status at randomization, we can see a clear benefit of using lipid-lowering agent. But this benefit is driven mainly by patients who are non-dialysis dependent. And you can see that for patients who are dialysis dependent, that there is actually an insignificant reduction in these events. And therefore, the guidelines suggested not treating patients who are dialysis dependent with lipid-lowering agent because of the lack of evidence for protection. And this may be related to the fact that patients who are already established on dialysis, they have a really very high background of CKD risk profile. And therefore, even with adequate lipid lowering, it may not achieve enough or sufficient degree of benefit to reduce cardiovascular event. What about in patients who are already receiving statins at the time of dialysis initiation? Well, the guidelines suggested that these agents be continued, and this is 2C. The rationale, of course, is from some of the studies. Well, the SHARP, 4D, and Aurora have not addressed this issue, but in the SHARP study, you can see that 34% of the participants in the non-dialysis group actually initiated dialysis during follow-up, and the benefit was actually observed in the non-dialysis group of patients in the SHARP study. And therefore, it will be reasonable to continue statins in this group of patients, recognizing that these benefits may be lower in non-dialysis patients, and therefore discontinuation of therapy may or may not be considered, but subject to the patient's preference, it may be continued or discontinued. Moving on, in patients over the age of 50 with CKD and eGFR more than 60, the guideline recommended treatment with a statin. And in younger patients aged between 18 and 49 with CKD who are non-dialysis dependent, the guidelines suggested treatment if they have one or more of these risk factors, namely non-coronary heart disease, diabetes, previous ischemic stroke, or an estimated 10-year incidence of coronary events more than 10%. Now, in adult kidney transplant patients, the guidelines suggested treatment with a statin for obvious reasons, and one of which, of course, would be the fact that these patients are taking agents that could promote dyslipidemia and also cardiovascular events. And this is 2A. Now, in adults with CKD, including patients treated with dialysis or transplantations and hypertriglyceridemia, the guidelines suggest that therapeutic lifestyle changes be advocated. Now, so much on a recap on the KDIGO 2013 guideline. Let me move on to talk about why lipids, and particularly saturated fatty acids, are so bad to our body. I would highlight the fact that these fatty acids actually promote systemic inflammation. So this is a recent review that our group has published by Li Bing, who was a PhD student at the University of Hong Kong, who has now graduated and moved back to Guangzhou to pursue his postdoctoral studies and also training in nephrology. But in this review, Li Bing nicely illustrated some of the crosstalk mechanisms between saturated fatty acids and toll-like receptor 4 in particular in the etiology of inflammation and insulin resistance. Now, of course, we know that toll-like receptor is actually part of the innate immune system, and it actually recognizes some of the pathogens and as well as danger-related molecular patterns, meaning our endogenous danger patterns, particularly in the face of diabetes. So this is a schematic diagram showing how saturated fatty acids will promote toll-like receptor 4 related intracellular signal transduction to facilitate inflammation. So here we see that saturated fatty acid stimulus will facilitate the recruitment of inactive monomeric toll-like receptor 4 into a lipid draft shown here as shown by the arrows, after which toll-like receptor 4 will form a homodimer in the presence of the co-adapter MD2. This complex will then undergo dimerization into two TLR4 MD2 complexes that would then move intracellularly to undergo either an MYD88 dependent signal transduction pathway, or by endocytosis to form an endosome to then promote MYD88 independent signal transduction mechanisms. This is a little bit complicated, and this is a little bit busy slide to show, but shown here, this shows the two pathways that I talked about. So on the left-hand side is the MYD88 dependent pathway in which the complex will recruit a number of molecules as shown here. And I think in the interest of time, I will not read out these molecules one by one. And then on the other side, on the right-hand panel, will be the MYD88 independent signal transduction pathway, also recruiting different molecules. But I think the end result of either the dependent or the independent pathway is to promote the activation of NF-kappa B. And as you know, NF-kappa B promotes intracellular inflammation. Now, how does these inflammatory process would then give rise to organ damage, in particular kidney damage, and also some of the systemic side effects? And these are illustrated in the next slide here, which I'm afraid is also a fairly busy slide, which I would like to take you through. And so this slide actually is an overview of saturated fatty acid-induced toll-like receptor 4 activation in different insulin sensitivity and also inflammation situations in integrated cells, tissues, and also organs. So TLR4 is actually robustly expressed in monocytes and also macrophages. Upon SFA stimulation, this would then facilitate the pro-inflammatory M1 phenotype in these cells via exaggeration of the production of related cytokines and chemokines, as shown here. And then these cytokines, of course, will spill over to the circulation and induce what we call systemic and local inflammation through NF-kappa B and also JNK pathways, which will then be followed by local inflammation and also insulin resistance, depending on the organ involved. So in adipose tissue, for example, adipocytes will be triggered to release pro-inflammatory cytokines, whereas in the liver, for example, hepatocytes also express toll-like receptor 4, and these toll-like receptor 4 molecules in the liver, of course, will be activated to then express a whole host of molecules as shown here, which would result in ER stress, macrophage infiltration, and also insulin resistance. Toll-like receptor 4 activation could also occur in skeletal muscles, and you can see basically similar particles or molecules are activated, leading also to macrophage infiltration, ER stress, insulin resistance. And you will also see that in the pancreas, the SFA would also induce the overexpression of inflammatory molecules and ultimately leading to reduced insulin secretion and enhanced macrophage infiltration into the pancreas. Interestingly, of course, also in the CNS, okay, in the central nervous system, SFA-induced TLR4 activation would cause different neuronal cell types to undergo inflammation, ER stress, and also the resulting insulin and leptin resistance, which of course, as you know, would also affect appetite and also be related to the onset or propagation of obesity. In the cardiovascular system, a similar phenomenon occurs in which there is inflammation in the cardiovasculature causing oxidative stress, macrophage infiltration, and also a whole host of damage, which would promote, of course, atherogenic cardiovascular disease. Now, so much about lipids. What about obesity and CKD? Well, for years or decades, we know of a relationship between obesity and cardiovascular morbidity. But how about in the kidney? This is a meta-analysis published in KI in 2017, showing that obesity actually did contribute to the incidence of CKD. And this is a more recent study published from a Korean group in AJKD, showing the relationship between obesity, metabolic abnormality, and progression of CKD. And in their study, they recruited over 1,900 patients, as shown in this flowchart here. And these patients were then followed for about 5 years. And And these patients were observed on the development of renal events, defined as a 50% reduction in eGFR from baseline or the onset of ESRD. And they correlate these findings with metabolic abnormality, defined as 3 or more of these 5 criteria. Number 1, hypertension. Number 2, hyperglycemia or the presence of type 2 diabetes. Number 3, hypertriglyceridemia or the use of lipid-lowering agents. Number 4, a low HDL-C level. And number 5, an elevated high-sensitivity C-reactive protein level. And you would see that these lines separate quite nicely, in which the renal events are lowest in patients who are non-obese without metabolic abnormality. And you can see a greater increase in the incidence of renal events with the development of metabolic abnormality, and also then with the development of obesity. So showing a relationship between obesity and renal events, in particular the progression of CKD. Now, I would then like to focus on some of the novel data that we have generated on the relationship between obesity and CKD. And this work is largely also done by Li Bing, and he has published a paper a couple of months ago in Stem Cells Translational Medicine, and I would like to present some of the results from his study. Now, first of all, at the cellular level, he performed in vitro study to show the effect of palmitic acid, which is a saturated fatty acid circulating in the body, believed to mediate most of the harmful effects of hyperlipidemia and obesity. So here you can see that when cells, particularly HK2 cells, are venotubular cells, and when these cells were exposed to palmitic acid, you can see that the cell viability was reduced. There was an increase in reactive oxygen species ROS generation, meaning an increase in oxidative stress, the increase of reactive oxygen species reflecting oxidative stress in these cells. And here in the middle panel, you can also see the reduction in cell viability and also the generation of ROS measured in a different way. And here on the right-hand panel, you would also see that exposure of these cells to palmitic acid will also lead to ER stress, endoplasmic reticulum stress, as shown by the elevation of these ER stress markers. And here, this is a diagram to show the increased ER stress in the HK2 cells. So these are DAPI staining the nucleus, and these are the ER stress marker. And when merging these, you can see the upper panel showing exposure to an equivalent dose of BSA, and the lower panel shows an exposure to palmitic acid, and you can see a definite increase in ER stress in these cells. And actually, this figure was actually taken to be the front cover page of the journal in that issue. Now, moving on from cellular injury to an animal model, Li Bing created a high-fat diet induced kidney injury mouse model. And so you can see that these animals were fed with high-fat diet, and these animals would then develop kidney injury, as shown here, mainly tubular injury, as you can see over here. But if you treated these cells, these animals with either iPS stem cells or bone marrow mesenchymal stem cells, as shown in the middle, in the right-hand panel, he observed an alleviation in kidney injury in these animals. And the bars here show the reduction numerically. And he also showed that in the gloms, you can see that the high-fat diet fed mice, they displayed glomerulomegaly and also some injury to the glomerulus, whereas treatment with iPS stem cells or bone marrow-derived mesenchymal stem cells given by tail vein injection would give rise to a reduction these injury. Next, we show that using these cells will also alleviate high-fat diet-induced ER stress. And as you can see, the ER stress markers BIP and also CHOP were reduced in high-fat diet animals treated with either iPS stem cell or BM, bone marrow-derived mesenchymal stem cells. Inflammation is a very important phenomenon in obesity, and therefore we also looked at inflammatory markers. Here we looked at IL-6 as an inflammatory marker, and here you can see that IL-6 level was elevated markedly compared to control in high-fat diet treated animals, and these were largely depressed in mice treated with stem cells. Apoptosis is also a very important phenomenon in kidney injury, and here we show an increased apoptotic tendency in the animals, which was reduced when these high-fat diet treated animals were treated with tail vein injection of either iPS stem cells or bone marrow mesenchymal stem cells. This is a diagram to show that stem cell treatment alleviated apoptosis, and here you can see the staining over here showing the apoptotic tubular cells in high-fat diet treated animals, which were markedly reduced in animals treated with either iPS stem cells or bone marrow mesenchymal stem cell. And the numerical values are shown here on the right-hand panel. Now, these stem cells are known to mediate their renal protective effect via the hepatocyte growth factor CMAC signaling pathway. So here we show the HGF CMAC signaling results in the kidney microenvironment, and you can see that these HGF hepatocyte growth factor is markedly induced by mesenchymal stem cells, as shown in the middle and the right-hand panel. And here you also see an induction of the HGF in the tubular compartment. So the glomerular compartment and the tubular compartment both increased by treatment with mesenchymal stem cells. Here we show the numerical values for HGF induction and also CMAC induction. So showing once again that these stem cells would promote upregulation or overexpression of hepatocyte growth factor and also CMAC. So to further substantiate these phenomenon, we performed co-culture in which the mesenchymal stem cells are co-cultured with glomerular endothelial cells, and you can then see the production or synthesis of hepatocyte growth factor in the cell culture supernatant, as shown here. Here we also show that in the glomerular endothelial cells, the incubation with these the conditioned medium, okay? The conditioned medium taken from the cells that were incubated with stem cells, okay? We also see an increase in the hepatocyte growth factor level. Lastly, we wanted to therefore see if recombinant HGF, okay, instead of the HGF stimulated by stem cells, would protect the tubular cells from inflammation and apoptosis. And here you can see that IL-6, VEGF, and also BAK expression were all reduced by incubation with recombinant HGF. Okay, so lastly, this is a visual abstract on the paper showing the effect of stem cells on high-fat diet animals. Okay, the high-fat diet would induce kidney injury in the obese kidney, and in the obese kidney environment, if we infuse the animal with mesenchymal stem cells, either iPS MSCs or BMM MSCs, these stem cells would cause the glomerular endothelial cells to overexpress hepatocyte growth factor, which would then act via the HGF-cMET axis to ameliorate some of the injury induced by high-fat diet. So in conclusion, ladies and gentlemen, I would like to summarize my talk by number one, telling you that lipid abnormalities and obesity are tightly linked to CKD, while the lipid-lowering agents would confer benefits in the pre-dialysis CKD population. Their utility in established ESKD and also dialysis patients remains relatively elusive. Lipids can induce within the obese kidney microenvironment ER stress, inflammation, as well as apoptosis. And these can be reversed using stem cell therapy, which can then lower the injury in obese kidney, and this may have further insight in our further exploration of using stem cells as a novel therapy for obesity and metabolic disease-related CKD. Now, last but not least, of course, I would like to promote the Asian Pacific Congress of Nephrology, which will be happening in just a few days' time in Hong Kong. But once again, this will be presented fully virtually. And I would like to urge for those of you who would like to register with at the meeting, featuring some of the well-renowned plenary speakers here, to actually register as soon as you can. As far as I know, although today is the 26th, the registration deadline is 25th, I know that this registration site will not close until the 28th. So with that, I would like to thank you very much for your attention.